Here are just some statistics to kind of illustrate this. In all of 2022, Africa saw 1,863 cholera deaths in all of 2022. Already in 2023, 10 African countries facing outbreaks have seen 660 deaths. So that's 1/3 of the annual total of last year already in the first month. So it's quite alarming. Malawi is the hardest hit country. Cholera cases have been found in all of Malawi's 29 districts. Cases are appearing in bordering countries and beyond as well. And making this crisis even worse is the flow of misinformation. Health facilities have actually been attacked as rumors about the safety of the cholera vaccine and misconceptions about safe burial protocols are spreading. So today, to give us facts on the outbreak, I will be joined by Dr. Otim Patrick-Hussey Ramadan, who is a regional epidemiologist at the WHO Emergency Hub in Nairobi. I will also be joined by Internews Media Mentor Jaya Sridhar, who will advise journalists on how they can cover this crisis, keeping in mind the harmful fake news that is circulating about this cholera outbreak. And we'll get right into it. First, I'll remind you that if you have a question for either of our speakers today, please type it in the Zoom chat box, and I will ask them of our speakers during this hour. I just want to mention that last week we had a survey of our participants to find out, get their ideas on where we should take this media dialogue moving forward. And I would say we had an overwhelming 77% of our respondents would like us to focus on disease outbreak preparedness in future media dialogues. And that's really interesting because that's certainly a direction that my project, the Rooted in Trust, is heading in as well. How to develop better systems, communication systems for responding more quickly and more thoroughly to the next outbreak, whatever that may be, the next pandemic. And I think that's also a priority for the RCCE technical working group as well. So we're all in line. It's the journalists' request for where we take it, and our own internal workings have pretty much aligned there. So I think we will be addressing that issue in future dialogues. I thank you to everybody who answered that questionnaire for us. That really is helpful. Now, okay, so without further ado, Dr. Otim Patrick-Hussey Ramadan is regional epidemiologist at the WHO Emergency Hub in Nairobi. He is a public health expert with more than 10 years experience in emergency preparedness and response, health and humanitarian crises, and public health surveillance in South Sudan, Uganda, Sierra Leone, Zimbabwe, Nigeria, and South Africa. Today, Dr. Ramadan will tell us the key facts about this alarming cholera outbreak. Dr. Ramadan, welcome back to the Media Dialogue.
Good afternoon, Wayne, and thanks for having me this afternoon. Apologies, I am not today joining from the regional office where I am usually based. I'm joining from Uganda, so you may not, I am actually on the road. We are doing the after action review for the Ebola response that just concluded recently. So I had to step out and take this and discuss with colleagues. And also secondly, just to inform you and colleagues that I actually moved from the hub in Nairobi. Now I'm based at the regional office. My focus now is on acute emergencies within the African region. And for the context of the cholera outbreak, I'm actually currently the WHO incident manager for the multi-country cholera response within the African region. So I'm happy to discuss with colleagues on this subject. I'd wanted to just lay some ground rule. I'll try to move very quickly on cholera before I can discuss what's happening with the current situation within the region. So Cholera, as we know, is an acute, really diarrheal disease caused by a bacteria we call the Vibrio cholerae. And it's a very serious disease because it can lead to severe dehydration and death in a very short time, with the severe form of the disease. And one of the concerns that we always have as WHO is that if patients are left untreated in the severe form of the disease, it can cause mortality up to 50%. But our recommendation as WHO is always that we want the mortality rate, the case fatality ratio to remain below 1%. And as you will see in most of the African countries, as we are responding now, we are way beyond that threshold of having the mortality below 1%. How is the disease spread? It's one of the oldest diseases, and in primary school we used to talk about the 5 Fs. Really, it's a fecal-oral transmission, and mostly a fecal contamination with the fluids, the water people drink, their fingers. The food can be contaminated by the fingers, the flies, and then also the different fields that people are working in. And one of the things that as people are trying to raise, we also have documented transmission at funerals in the way that the body is managed, but also the fact that a lot of cooking happens during funeral and water drinking. So transmission also happens around funerals, and we have seen transmission related to movement in the past outbreaks, movement of dead bodies also across districts or across countries. Now, one of the things which is critical about this disease is that the incubation period is very short, 2 hours to 5 days. So you can get an explosion of an outbreak in a very short time when people get exposed to contaminated water. So it can overwhelm a system in a very short time. If you have 200, 500 people exposed to contaminated food or contaminated water, you can have very many cases presenting in a very short time. And the symptoms, usually the acute watery diarrhea is the classic one. We always say that the stool is white. It looks like the water that is used for washing rice before cooking. We call it a rice-like water. And then there can be or there cannot be vomiting. Now, it's critical to know that up to 50% of the people, up to 80% of the people infected do not have symptoms. But you have symptoms in 20%. Of those who are symptomatic, 80% will have mild form. It's only 20% that will have severe disease with severe dehydration that can lead to death. Now, the diagnosis can be based on 3. The first one, which is very easy, is the clinical. Every good trained clinician, when they look at the stool of a patient with cholera, they can just know that this is cholera. So based on the signs and symptoms, this is very good for initiating treatment. Then we have rapid diagnostic tests, which are used for screening. And then we have the confirmation, which is done on culture, or of late, we have the polymerase chain reaction PCR that can be used. So for the categories of patients, we have those who have dehydration is the major issue, which kills people. And then we have those who have some signs of dehydration who can be managed quickly with oral rehydration solution. We have those who have severe dehydration who need IV fluids quickly to be able to replace the fluids and the minerals that they are losing. And then we have also children that need to be managed and supplemented with zinc. But in our context in the African region, we also have outbreak happening in areas with malnutrition. So you have to manage the person who is also malnourished, but also has cholera, and the fluid management in these people is also, you have to be very careful so that you don't overload them with fluids and also result in pulmonary edema and death. So one of the things driving our deaths is that we have children, but we also have malnourished people in some of the areas where the outbreak are happening, and the management is not being done well. Who are the population at risk? Cholera is basically a disease of inequity. Access to clean water is a big determinant in whether an outbreak occurs or not. So it disproportionately affects communities that lack access to clean water and sanitation, those who have poor access to healthcare facilities, communities with limited access to clean water. You have it happening in the peri-urban slums now. peri-urban areas in Blantyre and Lilongwe, in some of the areas, in IDP camps in DRC, in the flooded zones in Malawi, and in some of the unplanned settlements. So it really affects people with the limited access to both sanitation facilities and water. Now, our prevention and control is key, and it's a multi-sectoral response, looking at different sectors. I always emphasize that much as in the health sector, we deal with the issue of cholera, but it is primarily a water and sanitation issue. And most of the solution is by providing the water and sanitation. But we have to do the full package in terms of surveillance and reporting. We strengthen the healthcare system to manage cases. We engage with the community to understand how to protect themselves. And then we also use oral cholera vaccination. So the leadership, multi-sectoral, bringing all the different factors. No sector can do it alone, not the health, not the WASH. So we have to work together to be able to address these aspects. We have had a tool that we have used for the last decade in the oral cholera vaccination. It has been very, very helpful. In the situation in South Sudan, when we had the conflict in 2013, we were able to manage and prevent some of the big outbreaks because of the use of the oral cholera vaccination, both for reacting, but also for identifying hotspots and vaccinating people before an outbreak happens. So we have 2 vaccines that are available through the stockpiles, the Sanchol and Uvichol, which are really 2 doses taken orally. And these vaccines are very safe. They have very minimal side effects, and they have been used across our region very, very effectively. Now, the challenge we have at the moment is that because we have over 20 countries with outbreaks globally, these vaccines are not enough. So last year, there was a decision made to reduce the dosage from 2 doses to 1 dose. So most of the vaccination we are doing now is 1 dose. And 1 dose usually protects between 6 months to 1 year after vaccination. 2 doses gives you protection for 3 years. So you'll see that for areas like Malawi, when we have outbreak running, Cameroon, for over a year, the people who received 1 dose a year ago, they are already vulnerable now because the protection is wearing out. So we are really struggling at a global level to be able to meet the demand for the vaccine. And now we are not able to provide vaccines for preventive vaccination. We are only using it now for response in the countries where there's an outbreak. So having said that, where are we now with the outbreak in the region? So within Africa continent, we have 9 countries, 10 countries affected, 9 in what we call the WHO Africa region. The 10th one is Somalia. We have an alert that's being investigated in Tanzania, so we are still waiting for that. That is linked to the Mozambique outbreak. So we have the biggest outbreak happening now in Malawi in the southern region, which accounts for majority of our cases. And then we have Mozambique, we have Cameroon, we have Nigeria, which has been running since January 2022. We have Ethiopia, we have Kenya, and then we had 2 imported cases from Malawi to South Africa, which have been managed. So we don't consider South Africa to have an outbreak at the moment. And then we have Burundi, which started reporting earlier this year, and their outbreak is almost under control. And we have DRC in the IDP camp. So these are the countries where we have transmission. So currently, over 2,774 deaths and close to 120,000 cases reported in those 9 countries that I'm reporting. This excludes Somalia, which falls in a different region of the WHO. So you will see then that we have the cases by country, with the Mozambique, Malawi almost reaching 44,000 cases. And then we have DRC, we have Nigeria, Cameroon, as I've just explained. And you will see that if you look at the case fatality ratio for most of these countries, it's only in Mozambique, which is below 1%, and Burundi. The rest are slightly above the 1% that WHO recommends. And you can see Malawi is very high at 3.3, and we'll discuss some of the issues later. So we have been seeing an increase in the number of cases since 2021. In 2022, we saw a slight reduction, but then in 2023, we have had, in the first month, a significant increase in the number of cases. Most of these outbreaks are in the context of protracted humanitarian emergencies, like we mentioned. You will see that Malawi, Nigeria, DRC, and Cameroon are accounting for 91% of the cases and 95% of all the deaths since January. For Nigeria and Cameroon, their outbreak has actually been declining. Malawi has been increasing, but in the last 1 week, we have seen a decline. And Mozambique is the one which is coming up now because of the rains and flooding which happened in the last 1 week. So for Malawi, which was the area we wanted to focus on briefly, in the last 24 hours, we have seen 516 new cases and 14 new deaths. We see that from 18 districts, we see the top 5 districts being Lilongwe, Blantyre, Mangochi, Balaka, and Machinga. And you see that over 43,000 cases and 1,300 deaths have been reported. CFR, as I mentioned, of 3.3. But we have seen an improvement in the last 14 days. We see that initially all the 29 districts were reporting cases, but we have seen now only 27 districts reporting cases. So we are sure that we have controlled in the 2 districts. But if you have transmission in other districts, it can still spread to those 2. So response efforts have to go on. And then we have Mangochi and the Lilongwe really being one of the most affected districts at the moment. You can see that 55% of all new cases reported on 13th of February were from 3 districts. And then 55% of the new deaths were from 2 districts, Lilongwe and Balaka. So we are focusing our interventions in those areas. And as you would, somebody's mic is on.
Yeah, sorry about that, Dr. Ramadan. Please, participants, mute your microphones. We don't want to hear the background noise from your offices. Okay, thank you. Please continue.
Thank you. So when we look at the areas where we are having most of the cases and deaths, there have been efforts now intensified to address the transmission in those areas. I think yesterday and the day before, the president of Malawi was launching a campaign to try to end cholera, and there's intensification of community-based interventions in those hotspots so that we can be able to interrupt the transmission. The good news, as you can see in this epicurve, that actually we are seeing a downward trend on the daily cases being reported in Malawi. We just pray that we can be able to sustain that. If we sustain that for the next 7 days, it would look like now the worst is behind us. However, you take note that Malawi is still within the rain and cyclone season, and so any flooding or so can exacerbate the transmission as well. So I really wanted to end by talking about preparedness, Wayne, as you mentioned. I think what we have done, we have identified within the region countries that are at risk of cholera spread, both by being neighbors of countries where there is the transmission, because we have seen transmission from Malawi to Zambia, for instance, and then Malawi also to Mozambique. And so it's important that we really focus on preparedness. So we have identified these countries, we have supported them to do risk assessments as well and look at their readiness capacities. But I think it is important to identify in each country what are the populations at risk. And we have looked at these in terms of areas where there's insufficient provision of water and hygiene. We need to strengthen surveillance and have at least the rapid diagnostic kits that can be used at field level to quickly screen. We need to identify a key workforce that can help us manage the outbreak and identify our stakeholders, particularly the stakeholders in the wash sector, stakeholders that participate in the community engagement and risk communication sphere, so that we can quickly mobilize populations. We need to conduct trainings of healthcare workers and simulation exercises. We need to review our guidelines, procedures, and treatment protocols. We need to map our available resources. Now, Wayne, I would like to add that we are also facing a global pressure on the supplies that we use for managing cholera because of the many countries that are ordering. Over the years, we have developed what we call cholera kits that come prepackaged. We have the central kit, the peripheral kit, the community kit, which comes with the IV fluids, depending on the level, and ORS, and that was easy to be got from specific manufacturers and deployed. But those manufacturers are not able now to meet the demand. So we are now trying to piece these supplies one by one, getting IV fluids from certain manufacturers within Africa here to meet the demand within our region. So it's really, really critical that countries put a stock of IV fluids and ORS that they can use to manage if they have an outbreak. And of course, having funds and identifying actors responsible for different sectors. I would like to conclude on three things, I think, which some of the journalists have been asking. One, cholera is very easy to manage as long as the people present very early to the health facilities. Because of the profuse nature of the diarrhea that happens, people lose fluids and electrolytes in a very short time. So if a person comes to the health facility when either their kidney has stopped working because of the severe dehydration, or their heart is now having problems because of the imbalance due to the electrolytes they have lost, it is sometimes very difficult to be able to stabilize them. So it is critical that people who have this kind of diarrhea present to the health facility early. And we have been seeing these issues in Malawi because we have a number of people coming in, but they are coming in very late when they are severely dehydrated and decompensated, and it's very hard to manage and try to reverse that. The second one then is also that we cannot stop the cholera outbreak at the treatment facilities. We stop it at the community by addressing the issue of proper disposal of waste, hygiene, hand washing, proper management of fruits and salads, and ensuring that the water is treated. So that is where also a big focus should be on educating the population to do those things. But the population needs support to be able to implement those preventive measures. If they need to treat their water at the household level, they need the tablets that are needed for treating the water sources. So we need to support the communities to be able to do that. And finally, in 2017, there was a roadmap which was put together to eliminate cholera within a number of priority countries by 2030. And there are recommendations for governments to be able to implement measures in 3 axes that were recommended in terms of enhancing surveillance for quick response, a multi-sectoral coordination, and really ensuring that we work in a multi-sectoral approach to address the common drivers of cholera. And it's important then that we continue to advocate for these measures so that countries can reduce the risk of cholera and also help us overall contribute to the goal of eliminating cholera within our region. So I will stop here and then we'll take some questions if there are. Thank you.
Thank you very so much, Dr. Ramadan. Yes, that is very comprehensive. Yeah, we have one question I would like to ask you before we go any further. It's from Rachel James of UNICEF. She's asked, why are we seeing so many cholera outbreaks across the region right now? And why is the outbreak so severe in Malawi in particular?
Okay, thank you. Let me start with the first one. So within the region, we have 3 main factors that is favoring transmission, which has really triggered the kind of waves of transmission we have seen. The first one is that we have had an increase in climatic conditions that are related to cyclones and flooding within the Southern Africa sub-region. So you will remember that the outbreak in Malawi followed a tropical storm Anna, which happened in January 2022. And that damaged the infrastructure for water and sanitation in the southern part of the country where the outbreak started, and then it spread to the rest of the country. So those conditions, even now in Mozambique, we have seen an increase in flooding. Over the last 7 days, there has been a lot of flooding, and in Maputo, water sources have been really affected by the flooding. So when you have this flooding, it contaminates water sources, latrines are flooded, and all the fecal matter is carried all around. So it really increases the risk for a cholera outbreak. The second factor is now the drought-related factors. So you have in the Horn of Africa, you have Somalia facing a severe drought. You have parts of Kenya in Garissa. You have parts of Ethiopia. Those ones are also facing significant drought that has affected the available sources of clean water. So people have to use whatever water is available, even if it's a contaminated water source. So those are the things that also helping to drive that. But the drought is also associated with malnutrition. So you have malnutrition, and a malnourished person is at risk of so many other diseases because of the reduced immunity. So they are also at risk of diseases such as cholera. So those are factors which are mutually reinforcing, the drought and the malnutrition. The third one then is the conflict. So we have areas in Africa where there has been conflict and displacement. You have in DRC, for instance, the outbreak is happening in Nyiragongo, where there's an IDP. In Cameroon, some of the areas which have been affected by conflict, that's where you have people displaced and they don't have proper access. It also affected parts of Ethiopia, the northern Ethiopia, in areas where you've had conflict, and then also parts of northeast Nigeria, where you have had some insecurity also happening. So those three factors are the ones that have been behind the outbreaks now we have within our region. Now, Malawi specifically, and the issue is that we had a very severe flooding last year, and which triggered off that outbreak. Now, and the outbreak moved from the southern part of the country and spread to areas which even previously were not identified as cholera hotspots. Why did this happen? Of course, we were coming out of COVID, and then you have severe economic situations. The response did not get all the support that it needed to be able to contain that outbreak. You will also see that there are areas now, when the outbreak got to the shores of Lake Malawi in the fishing community, which is a highly mobile community, and the fishing community traditionally, they don't have access to clean water. So that really amplified the transmission. And then later it came to the urban areas, to the peri-urban areas, the areas surrounding Lilongwe and Blantyre. So we also could not be able to vaccinate preemptively because we did not have enough doses of vaccine, which would have helped to slow down the transmission. So now we have to deal with that compounded complex environment from all those challenges. And so I really want to encourage that in other countries. By the way, people have traditionally regarded cholera as a very easy thing. So sometimes when there's an outbreak, countries really don't treat it as seriously as it should be. But like I mentioned earlier, it has capacity to really explode very quickly, especially when you have compromised water sources due to the disasters that we have just mentioned. So for Malawi, it's really a combination of the different factors that I've explained, which has resulted in the outbreak that we are seeing now. Thank you.
Thank you. Esther Nakazi, you have a question for Dr. Ramadan. Would you like to go online and ask him now?
Yes, thank you very much, Dr. Ramadan. Yesterday, we had people talking to us from civil society, MSF particularly, and they said there is an issue of AMR among some of the patients that are being treated. Can you speak? What are your findings about it, and where is it happening? Because we heard it's happening in Kenya, but are there other countries that are facing that problem? Thank you.
Okay, so the issue of AMR, which is the antimicrobial resistance, is a serious issue within the region, and one of the issue has been that there is a severe misuse of antibiotics, and people prescribe antibiotics for all sorts of conditions for which there is no indication for using an antibiotic. So you see, traditionally for cholera, we don't recommend antibiotics for everybody, and antibiotics are recommended for those with severe disease. And it has the benefits is that, one, it helps to cut down the recovery time so that they recover faster, and then two, it helps to reduce the duration that the person will be shedding the bacteria in their stool, because somebody who has had cholera can continue to shed bacteria in their stool for up to 10 to 14 days after even they have recovered. So the antibiotic is indicated for those in those severe conditions. Now you'll find that because people have abused doxycycline a lot, which is one of the antibiotics that is being used, and then you find that people are being prescribed antibiotics and it's not working because of the abuse of the antibiotics. So that is something. It has not been reported in the other countries that we are seeing outbreaks in yet, but that's a concern, and that's why we always prefer a judicious use of these antibiotics within the outbreak response setting. But I must emphasize that the mainstay for managing failure to give antibiotic will not result in the death of a cholera patient. The failure to give IV fluids is what will kill the person because of the dehydration. So the focus really for healthcare workers is to make sure that the patients get enough IV fluids, and then that they are able to follow them. We have usually a treatment plan, plan A, plan B, plan C, and they manage them through that, and they are able to pull them out, particularly those who are in severe dehydration. So yes, it's important that we take note of the issue of the antimicrobial resistance, and we make sure that antibiotics use is only when it is indicated and not for everybody. And we don't also recommend mass prophylaxis with antibiotics in just for everybody. It's really should be prescribed by a clinician when it is required. Thank you.
Thank you very much. There are many more questions, and we will get to as many as we can. But first, I'd like to introduce Dr. Jaya Sridhar. Jaya is a health and development journalist and a medical doctor based in Chennai, India. She's also a pandemic media mentor with the Internews Health Journalism Network. Dr. Jaya is going to talk to us now about ways we as journalists can approach this cholera outbreak and the misinformation that is circulating around this outbreak. Welcome to the dialogue, Jaya.
Thanks, Wayne. And I actually didn't want to interrupt the wonderful flow of questions, such good questions from everyone. And Dr. Ramadan was in full flow, so I didn't want to actually interrupt, but I'll be very brief. I essentially wanted to share with everyone here that Internews has created a cholera toolkit that is intended to help us report better on cholera. And I'll just quickly, if you can share my screen. Can you share my screen? I mean, can you see my screen?
Oh, yes, we can see your screen. Yes, no worries.
Great. Yeah, so you can find it on the Internews website and also drop a link in the chat. And as you can see in the toolkit are some basic sort of tips on how we can report better. Among the first one is, first tip is like getting the definitions right. And essentially here are two main things that we need to get right. One is what is a suspected case of cholera? And the second is when say Dr. Ramadan announces that a cholera outbreak has been announced, what it really means. So this is important when we go out into the districts that are bordering districts where there is already a cholera outbreak, established cholera outbreak going on, and then we sort of range further afield to see if there are similar cases in other places abutting that area. And then it still could be a mixture of cholera and some other acute watery diarrheal disease. So we have to be careful about the way we report it and check with the outbreak responders, check with the local doctor whether these are confirmed cases of cholera or not. So the definitions are all here. It's very clearly written out. The second thing is, this is something that Dr. Ramadan already mentioned. So it's inequities at the bottom of these cholera outbreaks and these long-standing problems of sanitation and poor water supply. And to add to it, now we have the additional hard to control problem of climate change, which is wreaking havoc. So that's another long-term story idea to look at. But the issue of how communities need better sanitation and governments need to invest better, and even local governments or local philanthropists, employers, and so on. There's a lot of money in circulation among certain sections of the community, and the community can very well spend some of that to clean up their neighborhoods.
Sorry, Jaya, we're having problems with people leaving their microphones on. Mr. Pembere, please turn off your microphone.
Yeah. So, educate audiences on how cholera spreads. Dr. Ramadan explained that very well. It's the same diagram here, but here are all the information very clearly spelled out. And here are tips on how people can protect themselves and others. You can go through this toolkit. And I think this part here is really something that's very, very key. We'd like to call this crisis response journalism, because there's 2 or 3 kinds of journalism that we can do in a situation like this. Obviously, when cholera is spreading at a high rate, and there are several hospital admissions or people dying in the community, journalists need to really keep up these daily bulletins and alerts in a form of crisis response journalism, sending out important vital messages that people can immediately make use of through radio programs and through short stories, conveying how cholera spreads and what you can do to protect yourself, and really emphasize that early treatment can save lives. And, you can also pitch your stories around ORS Day, but during a cholera outbreak, every day is an ORS day. Every day is an ORS day, and this message can't go out often enough. So here are also bits of information that you can drop into your articles about what people in the community can do before you take the person to a healthcare facility. There's lots of first aid journalism that you can do that can help save lives. So here's information about what happens at the health facility, and how it's important to maintain hygiene, about disposing the clothes of people who's that have been contaminated with the diarrhea, which is highly infectious. There's also bits about recovery and safe funeral practices, and all these are very practical kinds of tips that we can pass on to our audiences. There's a little bit here to help us differentiate between cholera and other cases of acute watery diarrhea, but in the current situation, when it's clearly cholera established beyond all doubt, I think we can just keep the focus on cholera. So it's also important for us to, even after the outbreak is over, to continue to track the work of outbreak responders. We forget about cholera in between the outbreaks, but we need to keep that pressure up to ensure that we, this directly builds from Dr. Ramadan's slide on pandemic preparedness and outbreak preparedness, that we shouldn't forget about the impact of these outbreaks and the deaths and devastation that they cause, and not stop reporting on cholera the moment the outbreak is over. We have to keep up the pressure on decision makers to keep funds flowing to really clean up cities and reduce the risk of sanitation related outbreaks. So again, sensitive, accurate language, and we have to, above all else, stay safe while we're covering the cholera outbreak. And we need to keep ourselves clean, carry soap with you, make sure that you carry a bottle of water or 2 that you can use not only to wash your hands, but also for your own safety. Don't drink from any public sources when you're in a situation where there's cholera cases all around you. So there's additional links here to resources that you can use. I was also wanting to say that it's important to showcase trusted voices in our stories. So if we, outbreak responders will be running like crazy during the times of an outbreak, and they may not have time to give to a journalist. So these kinds of media dialogues where almost every other sentence of Dr. Ramadan's was like a quotable quote that we can use in our stories. Please let us know if we can use some of what you said in your presentation and directly drop it into the stories. So showcase the voices of the WHO, of the ICRC, of other trusted outbreak responders, and use them in your stories. to cut through hesitancy about vaccines and to cut through myths and misconceptions about cholera. That's important. So crisis response journalism is really the need of the hour at the current in the current situation. But the second thing that we need to do is to not let up pressure on governments to clean up the situation in our villages and towns, and to help improve sanitation and have a better vaccine stockpile and better supply situations, and to follow the story on outbreak preparedness between these outbreaks. And I think the third thing is we also have to keep in touch with outbreak responders between outbreaks to understand what the kinds of risk assessments that are being done about how surveillance is going on, and about whether if there was an outbreak tomorrow, we'd have the basic set of tools essential to respond to it. So these are some of the things that we can do, and please make use of the toolkit. I'll drop the link to it in the chat. Back to you, Wayne. Thanks.
Thank you so much, Jaya. That's wonderful. I have a question from Graziella Alamendral and Dingan Mitti. They're both sort of related on the same subject, so I'm going to sort of merge those two questions and ask them as one. And this is for either speaker, but I think Dr. Ramadan will want to address this. It's about supply of vaccine. Is there a plan to increase vaccine manufacturing, and how can global oral cholera vaccine supply be ramped up? Is there no way to tackle this problem? It's very worrying that pharma are dragging their feet. That is the question.
Thank you, Wayne. I think let me have a go at this.
Yeah.
So there's ongoing engagement to try to ramp up supply. So and we must acknowledge also that in the last 10 years, there has been significant increase in the stockpile quantity. It's only that now the demand outstrips what they have. So they had increased the global stockpile to up to around 34 million doses every year. But you will see that for the doses that are being manufactured now and the countries that are having outbreak, the number of populations that need vaccination is quite high. So there has been engagement at the strategic level with the manufacturers. Dr. Tedros was engaging, for instance, with the Korean manufacturers of the Uvitol to be able to see how that can be scaled up to address the current gap. There are also efforts in Africa, engagements ongoing with the manufacturer in South Africa to see, it may take a little bit of time, but to try to see that they can also take up manufacturing so that we can have manufacturing happening within the region to try and increase the production of OCV. So there are discussions going on, but you will understand that for you, there's a lot of investment that goes into ramping production of any pharmaceutical agent. So that will take some time. But from last year, when the 2-dose strategy was suspended, there has been engagement with the different manufacturers to try to speed that up. It may not be happening as fast as we want, but I think there's engagement ongoing on that. Thank you.
Thank you. I have a question from Sia Gajima Rejoice in Zimbabwe. I think this is both for Dr. Ramadan and for Dr. Sridhar. How best can we advise people on any outbreak as journalists? Can we best advise people on an outbreak, and how best can we advise them on health issues? That's a very broad question, but I'd be interested to hear our presenters' take on that, please.
I'll request Dr. Ramadan to go first.
Okay, I'll start on this. I think for me, the best I can say is that we need to provide the people with the right information. And in this context, there are 3 sets of information that we need to give. When we have an outbreak, one is to communicate the risk that we have this cholera outbreak happening in this place, in this place, in this place, and you can catch the disease because it easily spreads, and this is the way that it spreads. So the passing the information and timely to the population on the risk is very, very important. And the fact that everybody is at risk of cholera, by the way, though people say that it's a disease of inequity, but we have seen outbreaks even happening in very big hotels because They neglected it happening in a slum, but the people who work in these hotels come from all over. So you can even, we have seen guests at a conference being affected because there was a contamination that happened. So it's a concern for everybody. And there's nobody who is immune, even though you're well. As long as you come in contact with that contaminated food or water, you will develop the disease. So that's one. The second one then is, how do you protect yourself, particularly for communities that are in areas where they do not have access to clean water? How do they prevent transmission at the household level? I think that is very, very important. And giving them the basic thing, making sure that your drinking water in the house is protected. It is treated, and there are different methods for treating. It can be the chemical one. There are different tablets that are distributed during the outbreak, and they are safe. They can use them to treat their water. They can boil the water and make sure that after boiling it, it is safely covered so that there is no contaminant introduced to it. So making sure that their drinking water is safe, making sure that the food is prepared using safe drinking water, making sure that they wash their hands after using toilet and before touching or handling food. Those messages are very, very key to preventing the transmission. And waste management, the fecal waste management is key, because the bacteria is in the feces. If the feces does not come in contact with water or food, people will not get cholera. So how do you manage that waste? That is very, very important. So safe disposal of human waste, the feces, is important. Then lastly, when we have vaccine, it provides an opportunity for added protection. So the people have to go out and get vaccinated because it adds a layer of protection for them. Now, the third category of information is, when you fall sick, what should you do? We have been mentioning that you need to present to the health facility as early as possible. My fellow panelist was also telling the information that they can protect themselves at household level before the condition worsens. I know sometimes access to healthcare is a problem, but even how to make homemade ORS, which is safe, and there are guides. WHO has and UNICEF have a lot of guide on how to make ORS from salt and sugar at the household level using clean water before they present to a health facility. But we have sufficient in most of in all the countries. We don't have shortage of ORS, and they can be obtained quickly from health facilities when they present themselves, the ORS and IV fluid. So those are the three categories of information that we want to be provided to the population. You can cap it now by making sure that we do not facilitate the sharing of false information. Cholera is not new. It has been there. It is one of the diseases that was demonstrated that you can prevent it without even knowing what was causing it, just by eliminating the contaminated water. So it's not something new. There is no conspiracy theory about it. It is something that we can deal with, and ensuring that we protect the population and stop the transmission. Thank you.
Yeah, I'd just like to add to that by saying that repeating these messages every day through radio programs or through print articles is something that is a bit of a challenge for journalists, because the stories will all just sound like public health messaging. So I think it's important to also vary the voices that we use in our stories to convey these same vitally important messages that Dr. Ramadan just conveyed. A good idea may be to interview a cholera survivor or his caregivers to say how they gave first aid at home before taking the patient to the hospital. Another one could be a nurse practitioner who's tending to a patient, showcase her voice with her messages about the importance of vaccination. A third one could be a local a civil society organization, an NGO working in sanitation, to show how, the kind of work they're doing and the importance of boiling water. So by capturing these messages through interviews with different kinds of trusted voices in the community, could add some variety and color to the stories. And I also think it's good to showcase the voices of cholera survivors about their sort of experience with cholera, just tell people, how close they came to death and what they did and how the family took care of them to help them survive it and how the doctors attended to them. All of that may make for some depth and richness in the stories. But you can weave in all of these public health messages into every one of these angles and voices.
Thank you, Jaya. Selina Sifat, it's it's not really a question, more of a statement, but Selena brings up the issue of the myths that are circulating around this current outbreak. And we know in Malawi, there is this terrible rumor about the vaccines being poisonous, containing poison. Jaya, I mean, how do journalists deal with that kind? Because they're up against social media, which is everywhere, and there are no editors on social media, and journalists are tasked with trying to debunk this misinformation. Do you have some advice on how a journalist can even start to fight that wave of misinformation that's flowing everywhere?
It's a tough one, isn't it? This is something that we're encountering every day. And I think one of the lessons that we've learned from infodemic management is that not to repeat the rumors, or not to repeat something and then go on to debunk it. So replacing bad information with good information might be a better way. Don't repeat the bad information and reinforce it, but replace it with good information, and accurate information is a good way to go about it. The second thing is journalists are really good at having their ears to the ground in the community, and they know what's circulating on the grapevine and which is the most prominent or most dangerous rumor that can put people at risk of infection or death. So if there's limited space for a story, I'd say go for the most dangerous rumor, the one that puts people most at risk, and convey correct information through the most trusted source in your community that people will listen to, and put that quote, encapsulate the correct information in the headline or up there in the lead so that the message comes across very powerfully. Maybe Dr. Ramadan wants to add to it.
No, I think you've covered it very accurately. I will just summarize the issue of providing the right information and really making sure that we don't amplify the misinformation. That's key. But we have a lot that we can share on cholera outbreaks, different countries where it has happened, and the people that have experienced it. I also like the issue of amplifying the voices of people who have recovered. Cholera, though it's a very acute illness, but the experience is very, as an adult, you are not able to hold that stool and it just flows like water. It's something that nobody wants to experience. So it is something that we need to share with the rest of the population, and it will have impact. Thank you.
Thank you very much. We are at time, believe it or not. That went by very quickly. I just want to say as we wrap up that we have recorded this dialogue, and we will send the link of this dialogue out to everyone who joined us today. We'll also send some audio excerpts of today's presenters to our full journalist network via WhatsApp. And of course, as always, we'd like to hear from you about how you use the information you get from these dialogues in your reporting. Please send us your work. We would love to see what you're up to. And also, although you did a great job last week, continue to tell us what topics you'd like us to tackle in future media dialogues. Many thanks to Dr. Ramadan and Dr. Sridhar for joining us today. And until next time, for the RCCE Media Working Group, I'm Wayne Sharp. Thank you very much for joining us, and please, everybody, stay safe.